health, right? So cancer is obviously a very serious illness that can cause emotional distress, anxiety and depression, and other mental health issues. It is estimated that up to 40% of cancer patients experience psychological symptoms such as depression or anxiety. It is important that managing mental health during cancer treatment because it has a different type of fallout, right? So it can affect patients' quality of life, treatment outcomes, and adherence to treatment itself. Psychiatric medications are commonly used to manage the mental health symptoms in cancer patients. Okay. So what kind of psychiatric medications do we tend to use? I'm sure some of you guys are familiar with like the generic terms, antidepressants, anti-anxiety medications, antipsychotics, but also I threw in a little slide at the end about stimulants because more and more we use stimulants to help with some of these issues as well. So antidepressants, so we usually use those to treat depression and anxiety despite the name of it being antidepressant. It does help anxiety a lot. And other mood disorders. Commonly used types of antidepressants in cancer care include serotonin reuptake inhibitors, which are called SSRIs, and tricyclic antidepressants, which are called TCAs. So very long names. You'll probably hear me just say SSRI or TCAs, and I can clarify later if you guys have any questions. Anti-anxiety medications. So those are used to treat anxiety and panic disorders that will not help depression. Commonly used types of anti-anxiety medications in cancer care include benzodiazepines and buspirone. So benzodiazepines are Xanax, Klonopin, Valium, lorazepam. Lorazepam is also used in anti-nausea during chemo for a lot of patients. So kind of familiar with that. Antipsychotics. So those are used to treat psychotic symptoms. So what are psychotic symptoms? Those could be hallucinations. Hallucinations would be seeing things or hearing things that might not be there, like shadows or bugs or just misperceptions. And delusions. Delusions are just these bizarre ideas or sometimes non-bizarre ideas that just don't go away. Such as someone's following me, I feel like my life is in danger. Those would be delusions. Commonly used types of antipsychotics in the cancer care include risperidone and olanzapine. Olanzapine, again, is also used as an anti-nausea medication. So again, might be familiar with that one over the other antipsychotics. So we can do a deeper dive into antidepressants themselves. So types of antidepressants commonly used in cancer center, again, as SSRIs and TCAs. They're the most common ones. The mechanism of action, I won't get too deep into this because it tends to be very boring, but ultimately what SSRIs do is they increase the levels of serotonin. And serotonin is kind of the happiness neurotransmitter. So the more we have in our bloodstream, the happier we stay. And the serotonin reuptake inhibitors inhibit the reuptake, the taking back basically the serotonin out of the bloodstream. So it lingers around a little bit longer, so we stay happier a little bit longer. While TCAs work by blocking the reuptake of serotonin and norepinephrine. TCAs are a little bit different. They're more old school. In this day and age, we use them more for pain management. So some patients will get things like imipramine or amitriptyline and get them at night. It helps you get a little bit tired. And you usually get very low doses of it, but it can also have cardiac implications. So it's very important to just kind of monitor the amount and what you're getting and cardiac history for each individual patient. So indications for use, antidepressants are used to treat depression and anxiety and other mood disorders, as we mentioned. Side effects. So this is always a common question. So antidepressants can cause anything from sometimes feeling tired to dry mouth, GI dysfunction. What I mean by GI dysfunction, nausea, feeling like you're constipated or having diarrhea, sexual dysfunction, so more difficult to reach an orgasm, have libido, or sustain an erection. And that can be troublesome for some people. So it's definitely something that a provider should talk about. Patients should be monitored for suicidal ideations or behaviors. This usually has been seen in children and adolescents, and that's because initially when you take an antidepressant, it can be activating, so it can make you feel a bit more energized. But the problem is when you are more energized and your depression hasn't been treated well, Some patients, younger patients, have known to try to end their life by being energized but still being depressed. So it's something that we need to monitor carefully. All right, anti-anxiety medications. So what are the types? So benzodiazepine, like I mentioned, Xanax, Valium, Klonopin are those. Buspirone, that's a medication you use about 2 to 3 times a day. That is a non-habit forming medication. Benzodiazepines are habit forming, and those are commonly used. You can also use antidepressants in order to, I'm sorry, for some reason, my slide deck is going on some sort of an auto.
Yeah, someone else took control. Let me grab it really quick here. There we
I was
go.
like,
We're
oh, I can't
here.
speak this fast.
No, that's okay. I'm right here. Okay, so we're right here.
Yes, thank you so much.
Perfect,
All
of
right.
course.
Okay, so mechanisms of action. So benzodiazepine work by enhancing the effects of GABA, which is a neurotransmitter that reduces anxiety. So what else actually enhances GABA? It's alcohol, right? So a lot of times, I'll have a conversation with my patients saying, if you're going to get a Xanax, a Valium, a Klonopin, a lorazepam, whether it's for nausea or anxiety or muscle spasms, it is important not to drink on this because both things do the same thing. So a lot of people self-medicate with alcohol because it decreases anxiety. The bad news is, though, it does a whole bunch of other things like cause cancer, cause dependence, and give you liver damage, basically, and impair judgment. So some of those things are also true for benzodiazepines. But so they need to be monitored. And benzodiazepines in use with alcohol actually decreases your breathing drive in the body. So it tends to be a very dangerous combination. And so we would like to avoid that at all costs. Buspirone works by binding to serotonin receptors in the brain. Again, non-habit forming, does not impact your breathing, is a much friendlier version of that. So side effects. So common side effects of anti-anxiety medication are drowsiness, dizziness, and confusion. And benzodiazepines especially can be addictive. So what I usually tell patients is over the age of 65, probably shouldn't be on a benzodiazepine. It can cause memory issues, like short-term memory issues and confusion. It also builds up a level in the body because it's stored more in the fat rather than the muscle. And as we get older, unfortunately, we store more fat and our muscles kind of dwindle. So the benzodiazepine kind of hang out in there. So your levels are higher, so you might feel dizzy, you might fall very easily, and just have memory issues, which wouldn't be great. All right, next slide. All right, so antipsychotics, this always sounds scary, right? Sounds like somebody has severe mental illness and they need antipsychotics, but we use them in many different ways that are not necessarily just for psychosis. The common types are risperidone, olanzapine. The mechanism of action is they work by blocking dopamine. So dopamine is that neurotransmitter that can cause hallucination. So we kind of block that part. And when do you use this? So use it when you want to treat psychotic symptoms, such as hallucinations or delusions. However, you can also use antipsychotics as a augmentation therapy, meaning if your antidepressant isn't working that well, you can add in a little bit of an antipsychotic to almost squeeze out more of the antidepressant. It'll make the antidepressant work a little bit harder. Some antipsychotics, such as olanzapine, actually also help you with nausea, and they can be great for sleep. Patients who get steroids with their chemo treatments, for example, will notice that the first couple of days after chemo treatment, it's really hard to sleep. The anxiety may rev up itself. And so we actually say that, olanzapine during those couple of days of having chemo treatments is okay to take because you'd be able to sleep and overcome that anxiety. And it's non-habit forming. That's one of the more important things to remember, and it can help nausea. So it's a good add-on if you're getting chemotherapy. So the side effects, the common side effects of antipsychotics include drowsiness. A lot of times I tell patients to take it at night. There's basically one that doesn't make you sleepy, and that's called Abilify, but the rest of them will make you tired. They can cause dizziness because they can change your blood pressure from when you're sitting to standing. So that's where the dizziness sometimes comes in. It can cause weight gain. And patients should be carefully monitored for any type of movements like tremors or tardive dyskinesia. Those are these oral movements where you feel like other people might notice that your mouth is moving, but it does not bother the person that's happening to. And that's a matter of switching the antipsychotic medication. I'll go to the next slide. Stimulants. So I wanted to add this in because this is not something that a lot of people talk about, but stimulants are really used quite a bit in the cancer care, especially with my patients. And that's because they really increase the activity of the central nervous system, leading to alertness, wakefulness, and energy level. They're commonly used to treat attention deficit hyperactivity disorder, like in narcolepsy. I'm sure a lot of us have heard about in the 90s that kids were on a lot of these medications, and that's what that was for. But in the cancer center, it's used quite a bit, actually, and mainly to manage cancer-related fatigue. Medications that help us treat pain can cause a lot of fatigue. Radiation, chemo can cause fatigue. Anemia can cause fatigue. Having cancer itself can cause fatigue depending on what kind of cancer you have. So it can really help. It can really help not only with the fatigue, it can boost energy, it can work as an antidepressant, and in adults, it can actually work as an appetite stimulant. And it can make you feel cognitively more glued together, meaning your concentration and memory can improve while you're on this medication. So they're generally safe and well tolerated. They only, like Ritalin, which is what I usually give, is a very safe medicine. It only lasts about 5 to 6 hours. You don't have to worry about feeling terrible on it for a couple of days. If you don't like the way it feels, it'll kind of get metabolized out. And you can use it when you feel like you're going to have a big day, like a day where family's coming over, or it's the holidays and you need to engage more with the family, and that nap in the middle of the day is not going to cut it. You could take a Ritalin and find maybe that you feel more energized and have more endurance for yourself. So some of the side effects are important to mention. So if you take a stimulant too late in the day, you will have difficulty falling asleep or staying asleep. It's basically like caffeine. I mean, it's a stimulant, so it's important to take it early in the morning. It can cause, for some patients, feeling nervous and jittery. And if that doesn't get better, then that's probably not the medication for you. It can cause headaches, just how caffeine can cause some headaches. And in rare cases, stimulants can cause some more serious side effects like heart palpitation or high blood pressure or seizures. Although seizures, honestly, I haven't seen, and that's extremely, extremely rare. I tend to always make sure I do a good medical history. So if a patient has some sort of heart fibrillation, this probably wouldn't be the right medication, or untreated blood pressure. That would also not be the right medication for that. Okay, so considerations for use in general. So some psychiatric medications can have potential of interactions with chemotherapy or cancer treatments. So it's important for the healthcare provider to monitor patients closely and for potential adverse side effects. Patients with cancer may have a higher risk of side effects and complications from psychiatric medications, especially if you're older or have medical issues in general. So healthcare providers should work very closely with the patient to determine the most appropriate medication and dosage, and to monitor the patient for any adverse effects or changes in symptoms over time. So I think anybody who either has worked with me in the past or just knows kind of how I work knows that I'm very conservative. If you don't need a medication, I will tell you don't need a medication. And if you do need one, it's very important to make sure it doesn't have any drug-drug interactions, you are aware of the side effects, and that you get very low doses initially and you slowly go up on the dose. Starting on high doses is not going to be helpful because you'll end up feeling sick from a side effect such as nausea or constipation. And then my feeling is, my gut instinct will tell me you probably don't want to continue in a medication that makes you feel sick, and it may have just been the dosing was too high. So the conclusion here is, so psychiatric medication use can be important for cancer care, especially for some patients, but it really requires monitoring and for a physician to really work with you and understand the medical complexities of the case. It's important to have a thorough understanding of the potential side effects and risks for the patient. Everything is a risk and benefit decision. And it's really collaboration between, the patient and the provider. If a patient does not want a medicine, the patient does not have to take a medicine. But it's also important for the provider to really be honest about the medication, what side effects can be expected, and have a good working and therapeutic relationship with the patient so that there's trust and one can kind of work together and make sure you optimize the mood for the patient. And these are the references, just in case anyone's interested. And that's it. I'm happy to take any questions that you guys have.
Yeah, any questions, guys? I don't have anything in the chat. I did post our poll and a link to our YouTube channel in the chat. I'm going to edit this and put this up this afternoon too, if you wanted to go back and refer to anything. But does anybody have any questions? No? Okay. No, it doesn't look like it. So
Okay.
thank you so much, Dr. Madwadia, for your time and your expertise today. Absolutely. We really, really appreciate it. And if you guys have questions that come up later, you can certainly post them in the chat. I will be monitoring that for a little while longer. So let us know if you have any questions. Otherwise, I'm going to end the meeting and you all can, oh, wait, we have one pop in. Oh, look at you, last minute, Richard. Okay. It says, I have been on Wellbutrin for over 20 years. Could I be in line for a tune-up? So do we need to change that up?
I mean, it really depends, right? It's hard for me to say because obviously I have not met you and I don't know the whole story behind it. Wellbutrin is great. I mean, for many reasons. It can be a stimulating medicine, meaning it promotes kind of wakefulness and cognitively it's great. It's actually used for adults with attention deficit disorder as well. In the cancer center, it's a little tricky. And the reason I say that, it depends on the person. So if I have a patient who has a history of poor appetite, depending on if they're on chemo and they're not eating well and they're vomiting, then Wellbutrin would not be a great fit because Wellbutrin can cause anorexia. If somebody has a brain tumor and there is a side effect of, not a side effect, there is a potential of a patient having a seizure because of the brain tumor, Wellbutrin is absolutely contraindicated in that. So one should not be on that. But if none of those things apply and you just realize that, you know what, it's been a long time, I've been on Wellbutrin, it's not doing what it needs to do for me anymore, yes, then why not? I always encourage everybody to come in, have a second opinion. If there's no change, then great, you were doing the right thing all along. But if there's a different option, then why not try it?
Okay, great. And it looks like I have one more question here. What about medical marijuana and psychedelics like psilocybin?
So that's still being studied. I think a lot of my patients honestly are using edibles. So I always tell patients smoking is probably not the way to go because it comes with its whole slew of problems, right? We want to protect our lungs. So it does help as far as edibles. I mean, I would have prepared better if I knew that that was going to be one of the questions. However, there's a lot of studies still coming out. But psychedelics is not something really that I've really studied as much. I know that when I was doing fellowship at Sloan Kettering in New York, there was really some research coming out about that being helpful for patients with terminal illness. And then ketamine came out. So, I mean, ketamine for treatment-resistant depression has been great, intranasally and IV, so that can be looked at. As far as edibles are concerned, it can help with appetite and anxiety and sleep for some patients. And for some patients, it makes them feel uncomfortable. They feel paranoid. So it really is a trial and error. But because there's so many different people with different manufacturers, it's really hard to get a good, clean, cannabis that I can, recommend or tell you, I know exactly what's in here and this is exactly how it'll affect you. I won't be able to do that. But some patients do find it beneficial.